Okay, good afternoon. You are definitely the best people of this conference because you stayed until the end. So I think the idea of the session is that we hear from the different rapporteurs. There is 5 rapporteurs, and then I give a very short closing remark, and then Vana has a surprise.
So let's start with the community rapporteurs, and the first to present is Louise Hansford. Louise.
Thank you. Good afternoon, everyone. I hope you've had a fabulous conference. So Ollie, Ahmed and I have been asked to just sum up from the community perspective. So I'm not very well, so I just want to say a few words and then I'm going to hand over to these guys. Do you know, the start of the conference, Angie presented this word cloud from the community. And over the last couple of days, I personally have checked in with people who are from the community, and everything that they said 3 or 4 days ago, they still feel now. Do you know, and I feel privileged to be part of a network that really embraces community involvement, and it's at the very centre of everything INSHU does. You know, from my first INSHU conference, where there was 4 or 5 peer sessions to today and this week, when it's just been full of peer involvement. It's just beautiful progress, and it's, you know, I go to a lot of conferences where it's very, very highly academic, and I need to consult Dr. Google to understand what I'm being shown. You know, there's no barriers here. It doesn't feel like there's barriers. You know, people from all walks of life, from all disciplines, living experience. We all come together with a united purpose to improve the health of people. I just wanted to show one slide really, which was, behind the scenes, the community have worked phenomenally hard on this conference. Matt, who's just walked in, has brought some excellent presenters together. We've heard about the launch of the Community Advisory Board, but I'm not going to steal Ollie's thunder or Ahmed's thunder. This, for me, sums up, you know, like in this photo, Ollie led on organising the visit to the DCR, the drug consumption room. You know, you had 40 plus people from all walks of life just coming together, you know, to discuss best practice and just really start those conversations. You know, for me, it's been a beautiful conference. It's been the highlight of my year, and, you know, I'm sure I speak for the community when I just say thank you. And I'm going to hand over to Ollie.
Thank you, Louise. Thank you for the opportunity to report on my impressions from INSHU. We have seen many interesting contributions and studies from doctors and researchers from all over the world that help to improve the situation of substance users and their health. Often they have to use peers to better reach the target audience and find more acceptance among them. But also many projects initiated from peers themselves were presented at INSHU. First of all, there were the presentations by the winners of the 2023 Jude Bayan Emerging Female Leader Award. Jessica Morales wants to establish a community-based organization in Guatemala that will strengthen advocacy efforts related to drug policy and the rights of people who use drugs. And Kira Watson, who plans to develop a specific service for women who use drugs, inspired by the remarkable work of projects like Mesinier in Spain and Chemical Sisters in Italy. In the session on DCR, I heard from Joana Canedo from Portugal and Matt Bonn from Canada, who have started their own drug consumption room, completely unofficial in Joana's case and with very little money. They have shown a lot of courage starting their projects and also took a risk being held responsible if something bad happens. for example, acts of violence or overdoses. Then we heard about the DCR in Athens. It was particularly bad received by the community. It is highly organized like a hospital. First, you have to see a doctor who then decides if you are allowed in and at all, and it's far away from the places where the drugs normally meet. The community is demanding the right to have a say in how consumption rooms are set up and equipped, and also want to be able to deal with small quantities of substances on the spot. If they have to leave the place every time to look for and buy new substances, they are still at risk of being picked up by the police or suffer an act of violence. Spaces of consumption rooms are not the only part of the solution of drug problems. What is also needed is a safe supply throughout the supply chain, from production to transport to the distribution and consummation. Just think how many people die in South America in the production and smuggling of cocaine. Individual peers are more dedicated to solving detailed issues. For example, Matt Southwell, he wants substance users to get suitable injecting equipment and is working on how to improve the delivery of long-acting depot buprenorphine. Or my colleague Ahmed Said, who organized the syringe exchange in Kenya. There are many other examples of peers who stand up for the rights and health of substance users and bring about very positive changes in the society. At the next INCHU in Athens, we will certainly see many new projects and research results that demonstrate this positive change. However, I've been most impressed by peers who have not only brought about a great change in society, but have also developed themselves in a very positive way. Some of them have totally controlled their drug use and are now able to lead a life without substances. They have not turned their back on the community, but are still an integral part of it and serve as great role models for us. In this context, I would like to mention Louise Hansford, who spoke yesterday at the panel discussion, Surfacing Productive Difference. Louise told us a lot about her life and how it improved when she stopped using substances. One of her sentences in particular has stayed in my memory. Can I even be a responsible mother if I use drugs? I leave the answer to you. Thank you. I now hand over to Ahmed.
Thanks a lot. Ahmed, if you can try to keep to time.
Yeah, thank you so much. Let me recognize the leadership of INSU, the UNODC development partners, the community of the people who use drugs, and the academia and the researcher. Good evening. Yeah, let me just say a few things. This is one of the conferences I've seen the diversity and the involvement of the people who use drugs and also the researchers and all the expertise. And in this conference, we've seen as the people who use drugs, we've brought in experience, and you as academia and researchers, you've brought in expertise that need to merge together so that we may move the wheel of harm reduction forward. In the principle number 5 and number 6 is very clear that we need to affirm the people who use drugs in this program of harm reduction. We are also having a bold target and political declaration that we should have less than 10 people living with HIV facing stigma and discrimination. We should have less than 10% of people living with HIV, key population, women who use drugs, facing low gender inequality and gender-based violence. We need also to achieve less than 10% of countries with punitive laws. And I believe this we can achieve together when we are having the community of the people who use drugs in discussion, from planning, budgeting, and everything, and in terms of distributing the resources. We are having a bold target to see that the 30% of the program is done by the people, the community-led organization, 60% of societal enablers to be implemented by the community-led organization, and 80% of service delivery to be done by the community-led organization. I really want to thank every one of us. I really want to thank Louis. I really want to thank Olive here, because they did facilitate us in this region. One of the things I come to learn in Geneva, you need to read a Google map so clear, because you might get lost anywhere. So, but for that, I want also to recognize in the audience my boss there, Judy Chang. I also want to recognize my expert and Matt Southwell there. I also want to recognize female representation from Angie McBride from Sanpud. I think all these and all academia, I can see we have also a brilliant researcher, Akiyama, there. I can also see you. I think we all need to be together. Thank you so much, and have a great day as you spend back home and stay in Geneva. Please don't get lost in Geneva. Thank you, and over.
You know, Ahmed, I didn't know that Geneva was a place where you could particularly get lost. I think I've seen worse in terms of Google Maps and finding my way, but thanks for the community rapporteurs, fantastic. So we will just alternate, I think. The next one is Heather Valerio, giving us from the Kirby Institute in University of New South Wales, giving us epidemiology and public health. Please try to stay to time.
I will try to stay to time. This is my 6th INSU conference, which I really can't believe. And I think this is the largest INSU conference that I've been to in terms of just the breadth of research that was out there, all the epidemiology and public health studies. It was a bit of a challenge to synthesize this into a cohesive presentation. And if I missed your study, I'm very sorry, especially after I hounded so many of you for your slides. So I took away 3 key themes from INSU this year. Of course, there's a general theme to eliminate hepatitis C. I really wanted to look at how we are tracking, as we only have a few years left to reach this WHO target. How will we get there, and who do we need to support to get there? Another great theme that was coming out of INSU this year was really focusing in on the health and well-being of people who use drugs. INSU's now really concerned with what's going on beyond hepatitis C in this population, and really looking at how we can better treat the person and not just the disease. I also just am going to briefly touch upon some areas for future research, a little bit of a wish list for INSU in Athens and beyond. So how are we tracking towards hepatitis C elimination? Eirik from Norway highlighted the sustained downward prevalence of current hepatitis C infection among a cohort of people who inject drugs in Oslo, and similar data were emerging from other studies in countries that have actively prioritized DAA treatment to people who inject drugs. The successes of Egypt's universal screening has been remarkable, and they should be commended. But what do we know about the progress towards hepatitis C elimination across other settings, including low and middle income countries? Alison Marshall's review today really highlighted us that there's still work to be done to expand DAA treatment to people who use drugs, and that there are still some countries that are restricting DAA access due to drug use. We need to use this data to advocate in these countries to remove these restrictions, and Jason gave a really great example of how they've been able to leverage this review in Croatia to really start these conversations to get these restrictions removed. Who are we leaving behind in the quest to eliminate hepatitis C? Adelina highlighted the urgent need for interventions to reduce hepatitis C incidence among women, and multiple studies at this conference have highlighted that women are less likely to receive DAA treatment compared to men. This was the first INSU that had a session that was specifically focused on women who inject drugs, and I really did enjoy that plenary this morning. Nuria reminded us that the stigma and discrimination faced by women causes them to access NSPs and harm reduction at lower rates than men. So if we rely on the status quo and in enhancing hepatitis C care in these settings, we may continue to entrench these gender-related gaps in hepatitis C, and that our quest to eliminate hepatitis C will not be gender equitable. And Rita also called for women-specific services and really posed the question, why aren't these a standard? A theme that had come out of INSU this year was the role of peers and the importance of the role of peers in enhancing hepatitis C testing, linkage to care, and treatment. Julia highlighted the successes of peers in the prison setting. Andrew was able to use peers to successfully reach out to rural people who weren't able to access services in the past. Christiania and Sophia also had great examples of how peers could be used to enhance hepatitis C care, particularly in unhoused populations. So long as drug possession and drug use remains criminalized, the momentum to test and treat hepatitis C in prisons must remain a priority, and without this momentum, we cannot eliminate hepatitis C. We really do need to work together to set up enduring systems that test and treat people who are incarcerated in a single program that is simple, cheap, and fast, and this is essential. Point-of-care testing on reception is one way to do this, and we heard some great results from the national program that Jason presented today on how this can be used to link people into care. Rugi's presentation highlighted the importance of regular retesting in the prison, especially to capture treatment failures and reinfections, but we do need more data on prisons internationally, particularly low and middle income countries. And just to highlight that everybody in this room has their strengths, and we must be working together to monitor what's going on in prisons, to intervene where we can, and to actively advocate for harm reduction in prisons, decarcerization of people, and decriminalization. INSU has expanded into the health and well-being of people who use drugs outside of hepatitis C. Drug consumption rooms have been a hot topic at this conference, and Jordan's modeling project really highlighted the potential for drug consumption rooms to prevent a large proportion of new HIV and hepatitis C infections in California. But just to reiterate that harm reduction is not all about preventing bloodborne viruses, Samantha's research highlighted the importance of harm reduction in preventing more than bloodborne viruses. She reminded us that leaving opioid agonist treatment is very highly associated with suicide risk and self-harm. Harm reduction is a human right and it's best practice, and Ukraine's ability to adapt and provide harm reduction in a period of intense conflict is nothing short than impressive. We also heard some studies about HIV testing and treatment for people who inject drugs. Behzad's systematic review was a real call to action to provide more regular HIV testing for people who inject drugs, as his results showed that less than 50% were tested in the last year globally. And Kennedy's systematic review this morning really highlighted the lower viral suppression of HIV among people who inject drugs when compared to MSM and the general population. Another key theme and a very important takeaway from INSU is the number of preventable deaths that are happening in people who inject drugs. Sharon Hutchinson prevented on Scotland's drug-related death trends and the lives lost to the punitive drug policies in Scotland. And here we see that drug-related deaths had been on the increase, both for people on and off OAT, but a protective effect for those who were on OAT, really sort of driving home the message that it's very important to get people onto such programs. And Kira this morning reminded us of the consequences of the persistent barriers to care that women who inject drugs face. So Scotland has actually seen a drop-off in drug-related deaths, but this drop-off has not been observed among women who inject drugs in Scotland. So my wish list for future INSUs. I would love to see more data from low and middle income countries and more data that is presented on marginalized groups of people who inject drugs. That includes transgender people, genderqueer people, more data on women, migrants, especially migrants of non-English speaking backgrounds who are living in English speaking countries. I'd love to see some data on young people and really sort of highlighting intersectionality. I'd like to see some more data on alcohol use among people who inject drugs. Yesterday, Mark and Jordan touched upon the impact of COVID-19 on increased and excessive drinking, and really just raising the question, is it time to bring naltrexone or other harm reduction mechanisms for liver decompensation into the INSU conversation, particularly as we are trying to avert liver-related deaths. And I was really shocked that this was the first INSU to provide translation services, and I really hope that this continues as we go on, and really hoping that we continue to make the conference as inclusive as possible. So to conclude with a little bit of reflection, Philip Brugman opens the session with the phrase, "To see how far we've come, we must look back." And I would encourage you all to reflect after this conference on how far we actually have come. The bar set in the interferon era was actually very low, that it was nearly impossible not to move forward from that. And we have certainly come far from the interferon era, but there is so much further to go. Thank you very much.
Thank you very much, Heather, for summarizing all this work presented these days in 10 minutes. So we are moving on to Andrew Seaman for a clinical science section of the conference.
Good afternoon. So I didn't get a lot of guidance on this, so I just took liberty to put a very strong filter on what I saw in the conference, and I'll convey that to you. It's an honor to be here to summarize the clinical sciences portion of INSU 2023. I initially was going to present a PowerPoint presentation, and I just couldn't do it, and so you'll have to find something pretty to look at and just dream with me a little bit. So I'm going to try to talk about the big picture of the science in this conference and share where I'd like it to go from here. And I want to honor the vast amount of hard work and that went into all of these submissions and the sacrifice and the late nights and the weekends spent by so many of us here, but I won't be mentioning authors by name. I just want to, let's stay focused on the cause and the knowledge over attribution. So as often is the case, I'm leaving this conference with more questions than answers, and these are those that are central to me. So as a group of advocates and researchers and healers, we have continued to make steady progress in some areas, but are still facing what seem like insurmountable barriers in others. Progress is something to be celebrated, and yet sometimes iterative improvement just doesn't seem like enough to me. So how can we make this leap from iterative to transformative change? For the researchers among us, how can we ensure that we are asking the right questions, those that can lead to transformative change and radically different outcomes for those we seek to serve through this pursuit of knowledge? And what can we do to reduce our resilience on centralized healthcare systems and medical providers to allow all to achieve elimination? How can we restore the rightful power and autonomy of self-healing to the communities most directly affected by the war on drugs, by the impacts of chaotic substance use fueled by trauma and isolation, and by the structural and social inequities that have allowed hepatitis C to flourish in this global community? So I encourage you all to think about these questions and whatever comes up for you, and as we think back on these last few days. So what have we learned? Starting at the systemic and policy level, we've heard a global systematic review of country and regional HIV testing and treatment rates among people who use drugs, which show vastly different screening and treatment rates between regions and countries within each region. These differences often, but not always, follow the usual patterns of economic disparities. The key, though, I think, lies in the outliers. Those lower or middle income countries, or those affected by conflict like Egypt and the Ukraine, who have shown that what can be done when there's this laser-focused political will that is consistent to eliminate these viruses. Multiple studies also discuss the impact of health system stigmatization of people who use drugs, calling out the necessity to address stigmatization to allow people to safely engage in health services. Stigma is not a figurative or a philosophical issue. It is literally killing people by the hundreds of thousands. And this must change, and we need to address this, but this will take years of healing, and I'd like to call in the question in parallel to this work: are we, medical providers, even the right people to address the biggest issues surrounding hepatitis C in the health of people who use drugs? We need to seriously reconsider our role, and I believe decenter ourselves as healthcare workers and redirect resources and empowerment to those with lived experience of hepatitis C and substance use, and those who live and breathe the health of people who use drugs in the harm reduction world. So one study made a faint attempt to do this through centering and empowering peers to screen and complete hepatitis C pretreatment evaluation and facilitate direct-to-provider telemedicine treatment as compared to local referral. In the peer telemedicine group, people were 6 times more likely to start treatment and 4 times more likely to be cured, showing the critical value of peers and the comparatively lower importance of providers in hep C treatment. I hope that someday we get to the point where peers and community health workers can test and treat certain groups autonomously. Other barriers to screening and linkage to care were also addressed. We've made substantial progress on this since my first INSU in 2018. In Australia, a team showed that it is feasible to scale up point-of-care HCV RNA testing in community and incarcerated populations, which led to higher treatment uptake, especially in incarcerated settings. One missing piece, I think, is the ability to assess fibrosis status and pretreatment evaluation and the risk of decompensated cirrhosis without lab work. Without this, decentralized testing measures like point-of-care RNA and DBS may translate fairly well in a place like Australia, but in others where the medical model is very conservative, I worry that it won't have an impact on real uptake of test and treat models of care. A preliminary retrospective study evaluated a survey tool called the D-Check, which shows excellent capacity to rule out decompensated cirrhosis, but prospective validation is needed. We also saw randomized trials exploring hospital-based treatment versus outpatient referral, and another exploring a mobile nurse practitioner-led treatment model with or without a smartphone app-based modified directly observed therapy intervention, and neither showed a difference in SPR12, but both had high treatment initiation SPR12 rates in both groups. We also saw some significant additions to the literature showing that adherence to direct-acting antivirals does not have to be perfect to achieve cure. The key seems to be somewhere around a minimum of 50% adherence and avoiding early discontinuations and long-term treatment interruptions. And finally, we saw data showing high rates of early reinfection among houseless individuals and a qualitative study showing the central role of stigmatization and lack of social resources in qualitative experience of reinfection. But I'd like to note that this was the only qualitative study presented in long form at this conference, and I think this needs to change. Everything that I have ever done that had any impact whatsoever came either directly from the people that I care for or from reading qualitative research, and we need more of this in this conference. Which brings us back to our initial questions. How can we ask and test the right questions? By listening to and centering the people whose lives are impacted by our work. Never about us, or nothing about us without us, is not just a slogan, and it's not just about policy. With no intended judgment at all, let's think back on the research questions tested here that seem to have risen from direct feedback and design and programmatic input from people with lived experience and those that may have come more from a different perspective through observation. This is one path to break free of the iterative change into the transformative. If we continue the empowerment and resource distribution to people affected all the way through implementation. Another path might be through the use of radically different approaches, such as what we heard about the status of psychedelic-assisted therapy for disordered substance use. I mean, we must reach for these sorts of ideas that hold the possibility of more than steady progressive change. So I love this conference, and many of you here, I love coming back here every year, and I would love to continue in future conferences to join together and refuse to stop tweaking systems and relying only on governments. And how do we empower people to just build something beautiful where they are and not have to rely on changing these huge structural issues? And let's stop tweaking things and let's tear this shit up and make it anew. Thanks.
Thank you so much, Andrew. Very thoughtful. And you know, language matters, and you gave some beauty to the words, which is nice as well. Thanks. The next person, or the next rapporteur, is Models of Care, Alexandra Wade from Australia, Mid-North Coast Liver Clinic.
Thank you. I'm looking for my stool. There's a stool in the other room. I would like to thank the conference for asking me to do this. I say that whilst quietly swearing under my breath. Having never done something like this, I was not quite sure what to expect. So what you're going to get may not be what you're expecting. So hang on to your seats. I came into Switzerland a week or so ago. So I've had a lovely journey from Zurich down to here, and so we'll see some of that, and we'll see how we go. So one of the first points that I came out from the models of care is how are we delivering it? What vehicle are we using? And there's some beautiful vehicles around Switzerland, and I've heard different stories about using backpacks to take care out to people, bicycles with little packs on the back with fit packs and Hep C treatment, and I think from the Ukraine there were party packs. I love that idea of party packs, and of course buses. I've considered one of these for the Mid-North Coast. We thought we might be able to put a FibroScan in it and travel around. I love it. And I have, anyone who's heard any of my other talks, we have a big blue van, which I affectionately call the BBV, of course, and it appears like it followed me here. Literally this morning, this van approached me, and there it was. That's exactly the kind of van we have. So this is just up the road, and pulled up outside the conference as I came in today. So, you know, they're here. What box? And now Be Like Zig, which apparently is goat. I've named him Zig. This fella was at one of the lovely little country stays I had whilst on my way here. And I think we need to remove the cage of our models of care and start really, well, we're already doing it. And this is what I heard. There's lots of flexibility. We're integrating with services, we're collaborative, we're multidisciplinary, we're nurse-led. A lot of the services that I was listening to the models of care and I take part in are nurse-led. We have nurse practitioners doing a lot of the prescribing in Australia, and that's really helping us advance. We have pharmacists that are really on board. And I really loved, there was a study a model of care I was listening to with the social workers working alongside the nurses trying to get people housed. It was a Canadian group who were also using phones, and I just think we really have to broaden and look at lots of different aspects of care and people who can help out. And innovative, like I was saying with the hotel vouchers. I heard just these little snippets, and I love the little one-liners that I can actually take away with me. To seek and treat, feet on the street, I thought was really great, and that in my mind has the image of the backpack and going out and actually meeting people where they're at. Similar to, homelessness services in Australia, there's some really amazing homelessness services, and I work with homelessness services in a volunteer capacity, and the work that gets done on the ground in connecting with people. I'm not treating Hep C while I'm doing that, but I'm building rapport, and I'm trying to see, do they need socks? How are their feet? All of that stuff that we get the opportunity to do. And also after hours research, after hours outreach. I don't know that there's a lot of services that are going to pay for that, but I'm going to take it back, and I don't think my boss is going to be happy. But who knows? Which test? So testing modalities, a lot of that's been talked about in the different models, and use the suite, use everything, and I think we need to use everything. I do work with a lot of people who have poor venous access, but at times they've been given forms because they've got some other chronic disease and they actually want to have some blood tests done, so I'll work with them to try and get blood, but maybe not, they don't want a venous collection, so we can use the different point of care modalities, including the hepatitis C, the B, the HIV, the syphilis. We've started taking syphilis strips out with us on all of our outreach to try and help identify. We're having a bit of a, increase in syphilis in Australia. But with venipuncture, thinking again outside of the box, it's not necessarily just a needle in the arm. It could be a capillary collect. It could be a finger prick into a small little paediatric tube. And I've taken blood on people who've needed cirrhosis surveillance that way, to actually think beyond and push the labs. I tell them, this was a capillary collect. I need you to get as much as you can out of it. And then I'll send someone to a hospital in the home service to get a point of care INR so that we can do their cirrhosis surveillance. And also, we're big advocates for self-collection. If I can help you collect the blood, I will do that, because let's work together to reach to a target. Whose input are we listening to? And this was a drawing just up the road, and I just love it. I love it. There's like the eyes are just speaking to me. We need to be peer informed if we're not at least using peers when we go out, or coordinating and collaborating and following peer guidance, and we need to be non-discriminatory. And how do we do that? We sit and talk, we have conversations. In Australia, we talk about having a yarn, and I do a lot of yarning with the people I work with. And some of the stuff I've heard today and over the last few days, we need to ask questions. Is this working? Listen to the whispers, somebody said along the way, and I had to write that down straight away. Listen to the whispers, because I hear the whispers along through the clients I work with. It's like, those guys have got a bus, they go out there, but they'll go and work with the community. They've been at community housing, and if you go there, you can get some vouchers, or you might get some funds off your fines, or they might have hygiene products, because we carry feminine hygiene products in the van. We carry a lot of things in the van, but we can also put them in a car. We can also, we take them anywhere. And then ask for clarification of what I thought I heard. So not just to think I heard something in a whisper, but to actually check that what I heard was right or it's accurate. And then involve people in the solutions and the implementation. So again, it's been talked about already about having peers, people with living experience, people who have had family, people who have had successes, people who have had failures, and what worked, what didn't, and actually always be listening. What else can we do? And then once that implementation has happened, ask, is it still working? It worked, but is it still working? Do we need to change it again? And we've had to do that multiple times, where we might be doing dry blood spot testing in one place. it's no longer working there anymore. What do we need to do now? We need to go somewhere else, or we need to use a different modality or provide a different service, and to just keep reviewing and adapt. And then again, ask, does it still work? Like, not just once, not just twice, but always keep reevaluating. And then I heard this morning, know when to shout. I love that. Know when to make a noise and to advocate and to say, no, we need to do this, we're coming in, or no, I'm sorry, we're not going to go that way, we're going to go this way, or someone saying, advocating. And what frameworks? I know about the determinants of health. I don't want to appear ignorant, but I was listening to someone talk, and they said they had this assessment form where they go through the determinants of health. We kind of do that, but I've never actually done it in a structured way. And it was really brilliant. And for me, then I could take that away and go, hang on, I think about housing. We ask, what's your social situation? Do you have support? Especially from the interferon era, when we would go through that massive assessment that would take an hour. Who have you got at home that can help you? Do you need some support because you're going to feel like death for the next 6 months to 12 months? And that sort of dropped off a little bit. So it was really important for me to start rethinking that stuff, and the social work alongside the nurse, looking at housing, looking at, do they need any, nicotine replacement therapy? Is there other things that we can provide that can help? What income, what's, social supports could people have? And then the idea of the public health versus comprehensive care, high intensity testing activities, important, effort to find people, treatment as prevention was in there, wraparound services, but it's still person-centred, we're still looking at the person. And then comprehensive health assessments prior to treatment. It's the comprehensive care gateway into healthcare services, so actually accessing a health service would then help into other services like dental, or to podiatry, or to coronary care, or to wound care, identify, and it is also person-centred. So get out, get down, get real, let's get in amongst it, and let's save the planet, let's eliminate Hep C. So.
Thank you very much. So we move on to the Social Science and Policy Rapporteur, Guillaume Fontaine from McGill University.
Great, thank you so much. So I'm very excited to be talking with you about social science and policy research. I'll keep it engaging for the last one. First takeaway, prisons are key to HIV elimination, but critical barriers persist, especially in low and middle income countries. So to that point, the INSU Prisons team presented a survey that they did with a range of different INSU stakeholders, policymakers and implementers, and also people with lived experience, to see what were the access to prison-based HIV services across country income levels, and then conducted also an assessment of the different barriers that were reported by the different stakeholders across country income levels. It was interesting to see that some key barriers are really different across country income levels in terms of motivation by policymakers and funders, lack of knowledge, awareness, prescribing regulations, but also the cost of DAAs. And this will inform an advocacy toolkit for policymakers, engaging policymakers. This was also reflected in work conducted by the European Monitoring Centre for Drugs and Drug Addiction in the EU, where they conducted a study to assess the different barriers to different models of care for viral hepatitis elimination in European prisons. Second takeaway, like my colleagues, so peer-led models and community involvement are a powerful tool for healthcare engagement and equity. So numerous presentations highlighting how peer work and interventions are impactful, add value, reach excluded and marginalized populations for Hep C, but also HIV, viral hepatitis B, testing and treatment. What was really interesting was a presentation by Dr. Gabriel Vogt from Glasgow Caledonian University, highlighting how and why peer models work, So her conclusions were around the fact that not everybody with lived experience can be a peer worker. There's a need for specific personality traits, no hidden agenda. And they also highlighted some specific mechanisms of how people can become peer workers in terms of developing social influence, persuasion skills, and professional identities on top of their former self. They also highlighted how it is essential to build on some form of cascade of investment, starting with a peer-led organization and kind of a top-down approach. And at the bottom, we have healthcare providers who are instrumental, but they're not the primary focus of how these models work. Third takeaway relates to the persisting stigma around treatment access for people who use drugs. So Amy McEwen highlighted how, through a qualitative study, how there's a lot of discussions around access to treatment and cost of access to treatment when people are engaged in treatment for a first infection or a second infection for HCV. So a lot of stigma around that aspect, which is reinforced. And numerous healthcare providers also perceive that patients are the main barrier, So there are, a lot of blame put on patients still and individuals in that context. Fourth takeaway, drug policy research is crucial. There is a need to continue expanding the topics and focus of methods, going beyond harm reduction in treatment. So to that point, Dr. Alison Ritter and professor at the University of New South Wales, but also the editor-in-chief of the International Journal of Drug Policy, define, exactly what is policy across 3 different conceptual areas. So first, it can be a statement of government intent, actions of government, or governmentality, and then kind of I would say how outline different areas for drug policy research in terms of, looking at the formation of policies, looking at different policy positions and implementation of policies, outcomes of policies, and also the effects. So it was a fascinating presentation. I would encourage you to look at the slides if you can. And there's also a wide range of philosophical and theoretical approaches that can be used throughout this continuum of research. What was also interesting is, the focus on drug policy research related to harm reduction in treatment that we see at INSU, while there's a wide range of other types of drug policy research that is relevant to look at, and that should be a focus maybe for future research. Dr. Marie-Geoffrey Roustide presented on the criminalization of drug use in France. France is a country that invests a lot of money in harm reduction, but it is one of the countries with the most repressive legislation towards people who use drugs. So in practice, the French model of drug policy is dominated by a prohibitive regime. And she highlighted how the criminalization of drug use exposes people who inject drugs to HIV, HCV exposure, increases public disorder, and also impedes access to healthcare and harm reduction. So it was key to, in this context, reintroduce the voices of people who inject drugs in the public debate to change the discourse. There's also an interesting qualitative study that was conducted by Matthew Bond and collaborators around the decriminalization of drug use in British Columbia, Canada. And there was a lot of conversations around the threshold that was selected for decriminalization, but also a lot of discourse around distrust of police and potential for net widening within the context of police intervention and law enforcement around drug use possession. In terms of future directions, I have 2 slides. So there was a lot of emphasis on barriers throughout the conference. So, many different presentations on barriers to care, so barriers to testing, treatment, prevention, OAT. And I think, from my perspective as an implementation scientist, what would be interesting is to look further into multi-level approaches to assess determinants and factors which are essentially barriers. So making sure that we use implementation science frameworks to capture all the levels of the barriers that might be relevant. So outer setting, inner setting, organizational context, implementation process, but also that we don't miss critical factors related, for instance, to health equity that might be missed in some studies without a specific theoretical approach. So to conclude, in terms of other future directions, like I said, I think we should leverage implementation science a little bit more. That's what I would like to see in INSU 2024, 2025. We have decades of evidence in organizational theory, sociology, social psychology, behavioral economics to really assess in detail implementation barriers, but also design implementation strategies to promote testing, prevention, adoption of OAT that are evidence-based, evidence-informed, so we're not starting from scratch. I think there's also an area to look at in terms of looking at why and how specific interventions work. I think the presentation on peer models, looking at the specific mechanisms of how peer develop their roles is really interesting, especially if we're looking at replicating and scaling up these interventions in other contexts. And finally, I think, as I mentioned, there's a need to expand drug policy research to cover laws, law enforcement, policing, supply control, going beyond treatment and harm reduction. So, thank you.
Well, I think Nicholas is going to close the conference, right?
Thanks. So I'm not going to step up there. That makes it a little bit more democratic and I guess we're at the end of this wonderful week, end of INSHU 2023. It was maybe timely to bring it back to Switzerland, I don't know. It started with Philipp in Zurich. He told me it was much smaller, and he's up there. I think he's one of the founders of this wonderful conference. So it got bigger, and I think many of us here really quite like it, or like it a lot. It's a wonderful, as you can even say, it's from the rapporteurs, it's a wonderful mix of policy, community, very good research, and then as in all conferences, you can do a lot of wonderful networking. I had so many good side meetings, and I hope you have a lot of new ideas and collaborations and things that you're going to do until next year or in 10 years or whatever. That will transform our agenda and work a little bit more. And it's always a lot of fun as well, or for some at least. Last night was not so bad, I guess. And, in some way this is a difficult area to work in, and everybody of us, I guess, knows that we often get pushback from whoever it is around us, and so I felt we can, as well as somebody said, we can feel some progress in some areas. There's so many challenges and gaps, so hope that everybody is still motivated to work together and more on human rights and harm reduction and everything that's surrounded it. I think the thing that stands the most in our way is the war on drugs, to be honest. That's where we kind of stand. So I will thank the people individually who have worked behind the scenes and who make that possible. I've been part of the core committee from the first time. It sounds like it's a lot of work. It's actually not so much work because there's so many competent people that do so much work. And so it's the ASHM conference team, first and foremost. A big clap, especially to Amy Sargent and Michaela Mason. Then it's obviously the INSHU team, INSHU staff that is led by Emma Day, with Nikita Habraken, Olivia Davison, and Brooke Nolan. And the core committee was this year constituted by Anton Basenko from Ukraine, living in Brussels now, I think, Philip Bruckmann that I mentioned already, Erika Castro from Lausanne, I don't know if she's here. Jason Grabley, that I will introduce to you now. And Linda Montanari, I don't know if Linda's here still. I think she left already, maybe. It was a wonderful adventure, very nice calls, great ideas, very respectful, and we hope you liked it. Couple of our key ideas was to bring a little bit more low and middle-income country participation and presentations. we hope we achieved that a little bit. We heard from other European countries a little bit more than in other. There was translation, and that were some of our key ideas, and we hope you liked it. We felt it was quite a good week, but we are the least objective. So have a lovely Friday afternoon.
So I'm going to present the last slides of the conference just to introduce you to the next conference. I'm very happy that INSU selected Greece and my hometown, Athens, for 2024 INSU. Just to persuade you to come, I have to say that Athens is very well connected to other countries. It's a nice place with a very nice climate, especially in October, early October this time. Good food, nice accommodation. The city center is very close to the Athens Riviera. After the conference, you won't have coffee. And of course, Athens is a gateway for all the nice islands in the Aegean Sea, for those who have time to travel a little bit, and I think it's worth. The conference venue is situated at the center of Athens. Next to it, there is a metro station, so it's very accessible. And why are we happy that we, INSU, will be in Athens? The situation in Greece for people who inject drugs is far from perfect, but there has been a lot of progress in the past few years, and I think having the conference will make people, more active and perhaps energize our efforts. And in the past few years, we have done a lot of work in promoting testing and linkage to care in OAT programs and outside these programs. Very recently, there was a change in the legislation to increase access to naloxone. The first DCR was set up, and there is at last a shelter for homeless people who inject drugs. And all these are very nice, depicted in this video created by INSU and Connecting with Care. And I invite you to watch it. So see you in Athens next year.